Let's get started. Finish up here. So the good news is we've talked about most of the drugs. We're going to cover a couple other ones that are heart failure specific in more detail, but we've talked about most of the mechanisms and everything. So systolic heart failure is the primary thing we're going to discuss. It's the most common form of heart failure, and it's defined as reduced ejection fraction, so less than 40%, which means you have an impaired ability of your ventricle to fill with or eject blood, impaired cardiac wall motion, and 2/3 are attributed to coronary artery disease, so ischemic cardiomyopathy. So usually heart failure happens for a couple of reasons. The vast majority of them are post-MI patients, are at very high risk for developing heart failure. Some will develop a form of heart failure kind of acutely in the immediate phase after they've had their MI. Others might develop it more chronically, and some might get over it after their heart kind of recovers from the MI. Other ones might develop a reduced ejection fraction for life. The other third comes from other causes. So we talked about hypertension, increasing risk, some certain diseases that I'm not going to go into, toxins, so drug use. I think of like chronic cocaine or methamphetamine abuse being maybe associated with as cardiotoxic. Myocarditis, so some things like that. Valvular disease like endocarditis as well would be something to think about. But for the most part, we're talking about post-MI and hypertension being a big source of heart failure-related causes. Diastolic heart failure, 30% of patients have diastolic. Its ejection fraction is usually greater than 40 to 50%. So they actually have no reduced ejection fraction. They just have impaired ventricular relaxation and filling with normal wall motion. I think of this as almost like they have, as you get older, your age reduces your elastic properties of the heart. The heart wall kind of thickens, and it still pumps okay, but the filling volume is reduced a little bit. So your ejection fraction looks good because you're ejecting a lot of blood every time you pump, and you can actually get high ejection fractions with diastolic heart failure. But you can still have symptoms because you aren't pumping enough blood to the rest of your body. So again, for the most part, this is more of an age-related thing that we treat it quite differently than systolic heart failure, which can happen to younger patients, especially like post-MI. And here's some pictures everybody likes. Systolic dysfunction. One of the things I just want to talk about when I talk about the term remodeling, we talk about cardiac remodeling with certain drugs. Over time, the heart muscle kind of balloons and stretches out, and the goal is to get it to shrink back to normal size. And by decreasing preload and afterload and manipulating our medications, we can sometimes get people there, at least partially, depending on how far they are gone at first. Yeah, sorry.
No, you're good. I'm just a little confused with the diastolic heart failure. If you have reduced ventricular filling, how can you still have a normal ejection fraction?
Ejection fraction is, yeah, so ejection fraction is all about how much blood you can possibly get in versus how much is getting out. So if your ventricle is reduced in size, you can still fill it up completely and eject most of it. Everyone's going to have a little bit of residual blood left in there. So it's all about how much of their existing volume they have available to eject. So they might have a diminished volume, but they're still ejecting just fine because their heart muscle's working. Whereas a systolic patient is going to fill up and it's hardly going to push any out at all.
Okay.
Yeah. So symptoms are going to be common for both systolic and diastolic. Dyspnea, fatigue, edema, exercise intolerance. It's going to sound a lot like COPD, right? It's not terribly different than that, and they look very similar on presentation, or can look. Obviously different physiologic things going on, right? Our goal is going to be the same as any goal. We want to reduce the symptoms. We want to have clinical improvement, stabilize the patient if they're in exacerbation, get them to the point where we're reducing their morbidity and mortality, keeping them out of the hospital. Heart failure patients are the most notorious readmissions to hospitals ever. They're very difficult to manage just as a group, not because the patients are bad or anything like that. It's just a hard disease to work with. So like our hospital deals with a lot of heart failure patients. We have a huge amount invested into it. It's something we do well-ish, but we still have issues with readmissions. And a lot of it comes down to medication compliance in some cases. Take your meds, people. That's really important, especially with heart failure. All right. The New York, so this is staging of heart failure, and this is a table that compares the AHA stages versus the NYHA, or New York Heart Association. NYHA functional classification has been kind of the gold standard for classifying people for years. It's still used today, even though the guidelines are a little bit different. They kind of line up pretty much with NYHA. So A would be no real functional change at all. You might have some borderline ejection fraction diminishing, but really it doesn't look like it's affecting you at all. So no real structural heart. So maybe high risk or kind of like on the border of having heart failure, maybe post-MI or something like that. Structural heart disease, but without signs of symptoms, would be B. So again, maybe having some slightly ballooning of the ventricular walls. You have some limited ejection fraction, but overall it's not affecting your day-to-day life yet. C, and then classes 1, which are kind of combined here, and 2 and 3. So 2 and 3 is where you start to see symptom management with medications, really. So slight limitation of physical activity versus marked limitation of physical activity, comfortable at rest, less ordinary activity causes heart failure symptoms, are kind of the hallmarks of kind of that initial management phase of heart failure. And class 4 is severe heart failure, unable to carry out physical activity without symptoms or symptoms at rest. It's basically like kind of living in exacerbation constantly. Ooh, what's this slide? This is busy. This is a reference slide, so we're going to talk about all these things in detail, but this kind of tells you where you have options to use medications. This is body of evidence, so a 1 recommendation, a green recommendation means that's preferred, that's got good evidence associated with it, that's what we want to do. 3 obviously is harmful, so there's some things on here that we don't use. So like for example, they have ACEs and ARB combined, don't use them together, and say that again. There's other things on here that are kind of in the middle, so 2A's and 2B's, like whether or not it's really worth doing this or not. It's sort of like the evidence might lean yes, or maybe it's more like consensus group. When we got all of our cardiology friends together, we all agreed that that's probably the best thing to do, even though we don't have a journal to support that, or maybe we don't have the best body of journals to support that. So that's where we get the different gradients there. All right, and this is the rest of it too, in case you want to look at the acronyms or anything like that. So pathophysiology of left ventricular dysfunction, you have a couple different things we're trying to manipulate here. Neurohormonal activation is what's caused, what they call the cause of it. Really, if you think about it, it's excessive amounts of things that cause mostly vasoconstriction on the body. So norepinephrine, angiotensin II, vasopressin, endothelin, tumor necrosis factor alpha, which is an inflammatory marker. We'll talk about that more during like rheumatoid arthritis and some autoimmune diseases where it comes into play. And aldosterone. So all these things get elevated, and we want to shut them all down. That's really the function of the medications with heart failure. And so all of our drugs work on different aspects of these areas here. I don't really care, you know what endothelin is. We'll talk about that a little bit. I'll mention pulmonary hypertension very briefly, and we'll go through there's some endothelin manipulation there. Vasopressin, we talked about that kind of a little. It's more of an acute thing. We don't manipulate that with medications unless it's like in a severe case, and then we use it as actually a vasopressor because we want to increase blood pressure. So it's more like a sepsis management type medication. We don't really manipulate vasopressin to decrease this response. So really what we're focusing on is the norepinephrine component, and we manipulate that with our beta blockers. So norepinephrine is going to increase heart rate. We put the beta blockers on board. It prevents that from occurring as aggressively. And angiotensin II is going to cause a lot of peripheral vasoconstriction. And so we use our ACEs or ARBs to block that from happening. Those are the 2 cornerstones of heart failure treatment there. Aldosterone antagonists have a big role too, so we use spironolactone a lot there. And that comes back to the renin-angiotensin-aldosterone system. They're all connected there. It's a separate mechanism, but it's still kind of the same type of thing. 3 major body systems affected: heart, blood vessels, and kidneys. Following effects are seen, so you get increased demands on the heart, further increased neurohormonal activation. So it's an endless cycle. It's like the body's constantly in this stress cycle, and over time, your heart will eventually not be able to keep that up, and then you go into heart failure, and without treatment, you would eventually die. Hopefully, we can get you something before you die. Right? It's always the goal. We don't want to kill our patients. Again, you have some other things that happen too. Sodium water retention, which is where we have fluid management that comes into play with heart failure patients. Non-pharmacologic, this relies, there are plenty of lifestyle things. It's going to be the same stuff we talked about during hypertension, so cessation of smoking, restriction of alcohol consumption, fluid and salt restriction. This is a lot more important in a heart failure patient than it is in an essential hypertension patient. Those patients are like, yeah, you might want to watch your sodium intake. These patients, send them to the dietitian, make sure they understand completely how to watch their sodium intake, because fluid overload will cause an exacerbation and it will put them in the hospital. That's what we want to avoid. And also being able to weigh themselves regularly so they can detect subtle differences in weight. Even a couple pounds here or there can make a big difference in how much fluid they're retaining. Weight reduction with obese patients. This can be really tricky just because the patient might not be able to tolerate exercise, and then you're adding a beta blocker on top of it. So it's a hard one to say, but obviously in an ideal world, weight reduction would be helpful. Daily weight monitoring, again, is really important, so make sure the patient, I mean, it sounds silly, but understands how to use a scale, understands how to document their weight, has a journal to document their weight. They have to be able to weigh themselves daily, sometimes multiple times a day, and be able to trend that as well. Vaccinations, pneumococcal and influenza, just like our COPD patients, have positive mortality benefits on getting those two. Certain drugs to avoid, we generally don't use the calcium channel blockers in these patients, especially our non-dihydropyridines. They work, you might think, well, they kind of work like beta blockers, right? They decrease heart rate. In these cases, they actually increase mortality with heart failure patients. So we don't use verapamil, we don't use diltiazem in these patients. There's some antiarrhythmic drugs that we'll talk about in a coming lecture that we don't use. NSAIDs generally are avoided, which is tough for the patients who rely on them for osteoarthritis. But again, we want those good housekeeping prostaglandins in the body. They help us out a lot, so especially with this particular disease. So ultimately, we try and avoid NSAID use, especially chronic NSAID use. An occasional PRN, ibuprofen, no problem there, but like daily round the clock is an issue. Yeah. Technically, yeah, but at low doses, it doesn't have a huge effect at shutting down the prostaglandin. It's more antiplatelet at that effect, so that's usually what they're taking it for, but that's a good point. And then we'll talk about this class of drug that's really hard to pronounce, thiazolidinedione, that is for, I'm just showing off now, right? And that's for diabetes, and we'll talk about that next spring. There's a lot of interesting work in anti-diabetic medications. It's crossing over into positive benefits in heart failure and cardiovascular disease, which is kind of a cool forefront in medicine I think we're starting to see now. In fact, one of our newer classes of anti-diabetic medications just got an approval for use in heart failure. I don't have it in this lecture because it's new, but I'll talk about it more when we talk about diabetes, so don't worry about it right now. All right, systolic heart failure. So what are we trying to do? Preload and afterload. We want to preload is the volume entering the ventricle, so think about this. How fluid overloaded is the patient? How much resistance do they have? How much vasoconstriction, I should say, do they have on that side of the body? How much are they pushing towards the heart? So if you have fluid overloaded combined with peripheral vascular resistance, that's where you have a lot of pressure going in on preload. So if we can do two things to reduce that by vasodilating and decreasing volume, there's a nice mechanism, a couple mechanisms we have at play right there. Afterload, resistance left ventricle must overcome to circulate blood. Super, super important because that's where your systolic left ventricular dysfunction is taking place on that side of the heart. So if we're decreasing the resistance on that side, it allows for the blood to be pumped out easier. Your heart isn't getting that back pressure quite as much, and you don't get that ballooning effect, or at least your heart can hopefully remodel a little bit if you can decrease those two things. So they work together. They're both important for heart failure management. Underlying CV disease, hypertension, blood pressure goal is 130/80. Again, most of these patients are going to be at that goal or way under it because we really target aggressive doses with our beta blockers and ACE inhibitors in heart failure patients. And the odds are they're going to be hypotensive. You shouldn't really have to worry about hypertension in a heart failure patient if they're on optimal medication. So for that, you can kind of kick that to the side for now. Other things we want to look at, you might have seen on that big long table with all the evidence stuff on it, there was a statin note that said statins have negative evidence. Alone they do. Statins don't do anything. So statins lower cholesterol, right? We haven't talked about that, but I think most people know what statins are. Statins lower cholesterol, and certainly cholesterol management is a good part of cardiovascular care in general. It has nothing to do with heart failure directly. Certainly it can prevent another heart attack from happening though, which could have caused the heart failure, and we don't want that to happen. So they're all connected, and oftentimes patients will be on cholesterol management, but it's not really directly related. And there's no evidence that being on a statin alone prevents heart failure from happening, because at this time we're talking a purely structural disease of the heart. And so the fact that the arteries are blocked, yes, that's important in the acute phase, but for the chronic heart failure patient, it doesn't really matter quite as much. Yeah, the other things I don't really want to talk about right now. All right, let's get on to the meds. So first step, get rid of fluid. With all patients, they're going to be on some sort of a loop diuretic regimen. So our loops, remember, are potent diuretics that get rid of fluid fast and don't last very long. The nice thing about these is the patient knows they're going to take their loop diuretic, let's say every day at 7 in the morning. They can kind of plan their bathroom schedule around it. You don't want to take a loop diuretic at night for obvious reasons, unless you're a night owl, and that's probably a whole different story. But so like sometimes I'll see people, like somebody gets admitted to the hospital at 8 and they order their loop diuretic, and our computer system defaults it to an 8 p.m. start time because it's stupid. Sometimes you're like, why would you do that? So yeah, just watching that stuff if you're working with patients where there's like automatic dosing intervals and things like that. But using common sense with loop diuretics. A lot of people take them twice a day, and if they do that, they're usually doing it in the morning and like at 2 p.m. or something like that. You don't want to take it after 6. That's kind of a good rule of thumb. All the loop diuretics are equally effective. They have varying degrees of potency, though, so we kind of work our way up. Furosemide is the most common one by far. It's the one everyone's going to start on, or Lasix is the brand name of that. Some people might not need to be on a daily loop diuretic. They might take it as needed. So if they have well-controlled, well-managed heart failure and they're optimized on their other meds, they actually shouldn't really be accumulating fluid, depending on where their disease is at, I guess. But a lot of patients you might see, like, take 20 milligrams of furosemide if you're gain more than 2 to 3 pounds in a day or something like that. And that's, again, where the weighing yourself daily comes into play and knowing how to use those medications to keep yourself from gaining so much weight that you end up in an exacerbation. Once you get too much on board, it's hard to get it off with just oral loop diuretics alone, and that's where we get into trouble. So the loop regimen is really important. Now, interestingly enough, fluid control has nothing to do with mortality benefit. You don't improve somebody's risk of dying if they are on the loop diuretic. However, it does have huge quality of life improvements. It decreases symptoms. It can keep people out of the hospital. It improves exercise functionality. So all those things could probably contribute overall to the greater view of the mortality of the patient. But statistics-wise, it's the other drugs that are doing most of the work. This is more of a convenience thing to keep people who are gaining a little bit of fluid incrementally over time, to keep that in check. And I should just say, we'll talk about this more with CKD, but you can give these IV too. So if somebody comes in with an exacerbation, you can really load them up with loop diuretic and force the kidneys to push it out. They are a little bit slow. Even if you give it IV, you're probably looking at about an hour to get the kidneys cranking up to get that urine production going. They don't work instantly, so that's the one caveat. All right, again, these aren't monotherapy. These are kind of an add-on, but they're essential. Does that make sense? They don't give us our good mortality benefits. They don't have the good statistics behind them, but they're essential for the disease. If somebody comes in and they're fluid overloaded, 1 to 2 pounds of weight loss per day until their weight is back to normal is preferred. If they're hospitalized, you can be aggressive with that, and especially if you're monitoring their electrolytes. So loop diuretics waste potassium and magnesium, so all patients on a loop should be on a replacement protocol where they're getting their mag and K checked regularly and getting it replaced regularly. So it's just a side effect of doing business with heart failure patients. You're going to waste their K and mag. You just need to be able to replace it appropriately. So like at our hospital, we have replacement protocols where it's all nursing run. So as a provider, you just enter a potassium replacement protocol, and a nurse will check the lab, plug it into a calculator. It tells her how much, him or her, excuse me, how much they should be dosing, whether it's oral or PO or IV. Those are 2 options. And they'll just go off of that. And as pharmacists, we kind of make sure they did it all right and verify it. You actually don't see the potassium dosing. You just follow the lab trends and see how that goes. So it's really nice. A lot of hospitals work like that and have nursing run protocols that are convenient. So you don't have to micromanage as much as I'm making it sound like. On the outpatient side, it's a little more tricky, just making sure your patient's stable. And then a lot of times they'll get a K replacement daily. So they might take their Lasix every morning. In addition, they're taking a potassium supplement every morning too. So that's really common with these products. Magnesium daily supplementation is not as common. They don't seem to have as huge of an impact on mag wasting. However, mag and potassium work together in how they get, what am I trying to say, like uptaken in the GI tract. And so if you don't have one, if mag's low, potassium has a really hard time absorbing and becoming bioavailable. So you have to have both. But usually mag's not as big of a deal. It's the potassium wasting that's a big issue with loop diuretics. It's something you have to watch out for. Thiazides can be used, but only as adjunct. And so I mentioned metolazone. That's like if you have somebody on a high dose of daily loop diuretic and you need a little bit of a bump over that, the metolazone PRN has a synergistic effect with the loop diuretic. And so that's where you'll see that used. But thiazides generally aren't used in heart failure, especially not chronically. Okay, so ACE inhibitors, talked about this, blocking angiotensin II, one of our neurohormone issues here. ACE inhibitors have proven mortality benefits, decreasing mortality 25 to 50%. Results with ARBs are inconsistent, whether they have that same benefit or not. Again, this is why people generally prefer to have somebody on the ACE versus an ARB. ARB for tolerability, yes, you could use it as an alternative. The guidelines would say that's okay, but for the most part, you're going to do the 25 to 50% here. 30% decrease in hospitalizations, symptomatic quality of life improvements, decreases afterload primarily, a little bit of preload too technically. Required therapy for all patients with left ventricular dysfunction. So definitely need to be on an ACE inhibitor or something in that class. Beta blockers, again, another required therapy, 35% decrease in mortality. Dosing beta blockers is tricky because people get bradycardic on them and hypotensive. So again, we want to push doses. Like for example, somebody with essential hypertension, you might start them on carvedilol. Like I don't know, carvedilol dosing's weird. That's a bad example. Let's talk about metoprolol. Metoprolol, start somebody for essential hypertension on 25 milligrams a day, and then a heart failure patient, and that might be fine. That might be perfect for them, controls their blood pressure or whatever. If you're going to use a beta blocker. For a heart failure patient, you're looking at like a 100 milligram a day dose target. So you try and push people up to that. And again, 4 times the amount, that's additive side effects. People don't always tolerate that. So the goal is to get them there, but you might not make it. So you try and get them as close to that as possible, but know that you can have problems doing that with a lot of patients. And again, hypotension and bradycardia is what limits you there. 25% decrease in hospitalizations with optimized beta blocker therapy, symptomatic quality of life, and again, another required therapy here. Now remember, these 3 are the only ones that can be used. And metoprolol specifically studied has been the extended release. Metoprolol comes in 2 forms, regular and extended. And the extended release is the only one that's technically approved for heart failure. That's the only drug I can think of that comes in multiple forms where one form's only approved or only used for one specific use. So you could use that for blood pressure too, or other things, or MI. You can use the extended release. That's fine. It's more convenient for most patients, and it's cheap. It's been generic for a long time. But for heart failure, you can't use the regular release. Well, you could, right? But you aren't supposed to. I'm not going to say you can't, because physically, yes, you could write a prescription for it, right? But you shouldn't. Target doses, usually, again, quite high. We're blocking sympathetic effects in the heart. Carvedilol provides that additional alpha blockade, which is why generally it can be more preferred over it. I would say, again, in those respiratory patients, metoprolol would be the better choice. And really, I don't think evidence would push it one way or the other. I think either one is really fine, but I see carvedilol used a little bit more by our heart failure docs. Again, why? Probably because that added alpha blockade benefit. Okay, aldosterone antagonists. Spironolactone is going to be the preferred one here. We talked about these briefly in the context of potassium-sparing diuretics. But in this case, they're directly blocking the effects of aldosterone, which can have some increases in that whole renin-angiotensin-aldosterone system. So you can end up with increases in the way that angiotensin II gets potentiated and also the way that the whole system gets activated. It's kind of like the last step. So they tried using this in heart failure patients and actually have found pretty good mortality benefits, as you can see there. Approved for NYHA class 2 to 4 heart failure with ejection fraction less than 35%. So this is the first drug we've talked about with an actual criteria behind it. The other 2, if you have heart failure of any kind, which is probably going to be 2 or more, 1 doesn't really count, right? Then you're going to be on those 2 drugs, regardless of your EF. If your EF is less than 35%, that's when you add on the aldosterone antagonist. Or if you have left ventricular dysfunction immediately following an MI, you're going to be on spironolactone. And I say spironolactone because that's the one that's used way more than eplerenone, but they're both technically the same thing. They have some issues. So if you have diminished renal function, serum creatinine greater than 2.5, creatinine clearance less than 30, so CKD patients wouldn't qualify for these. Or if your potassium's elevated, you aren't supposed to take them. You can decrease the dose by 1/2. So let's say you start somebody on an aldosterone antagonist. They have normal potassium. Their potassium bumps above 5.5, half the dose, and see if that does the trick there. The one thing about these medications is with heart failure patients, we use really low doses of them, like 12.5, 25 milligrams of spironolactone, which doesn't mean anything to you. But if you wanted to actually get diuresis effects from them, you'd need to use like 200 milligrams. So we're using really small doses just to get that baseline aldosterone antagonist effect. So it's a very different mechanism than how we talked about them before in the diuretic context. Really, you shouldn't be getting much diuresis from these at all with this dosing. Side effects, there are a number of them. The one that I always remember is a 10% incidence of gynecomastia. So if you have male patients, they might not be super happy about that. It's a relatively common side effect with it. Digoxin. So kind of the solo heart failure drug here. It also has some use in AFib as well. Digoxin is a cardiac glycoside. It's the only one on the market, I believe. Its mechanism of action inhibits sodium potassium ATPase in myocardial cells and promotes calcium influx. You get a positive inotropic effect and some rate control effects as well. So it doesn't increase the rate, but increases the way that the heart can pump blood. So you get force without an elevated heart rate. So it works in synergy with the beta blocker. There's no real mortality benefits. However, you do get improved exercise tolerance, general symptomatic relief, and decreases hospitalization, which if you get those things, it's hard to believe there's no mortality benefit there, but I guess statistically they haven't detected it like they have the other ones. It is renally adjusted. If you have poor renal function, you can still give it. Sometimes people are on like every other day digoxin, and that's fine. I don't really care about the hepatic part of it there. Role in therapy, NYHA class 2 to 4, despite being on a beta blocker and ACE inhibitor with symptoms. So if they're on optimized beta blocker ACE therapy, still symptomatic, that's where you add your digoxin on. Digoxin has a bit of a narrow therapeutic index. It's easy to get toxic on it, so you do have to watch it with renal function. And again, you can dose it correctly and you should be able to avoid it. But we do serum concentrations of digoxin. So like 5 to 7 days after starting it or changing the dose or adding something that might interfere with its metabolism, or if somebody has an increase in serum creatinine for some reason, that would be times to monitor digoxin therapy. Digoxin has a lot of nasty side effects. It's really, really toxic if you take a lot of it. But again, at the doses we give, it's relatively safe. CV related, you get arrhythmias, heart block. It does its job a little bit too good. And you get CNS effects, confusion, altered mental status, hallucinations. Blurred or yellow vision is common with toxicity as well. And this is my fun fact of the day. This is kind of a funny, I don't know, I like weird historical facts. So this, I don't know if this is true or not. It's speculated. I should put that out there right now. But Van Gogh went through a yellow period, as they call it, where he painted a lot of very bright yellow hues, and people think that he might have been toxic on digoxin. You know, whether that's true or not, I don't know. But this is a painting he did of his physician, whose name I forget. But this is the foxglove plant, which is how digitalis was ended up being synthesized from, and how they isolated the molecule and what digoxin is based off of. So there's thoughts that he might have been self-medicating with digoxin either for heart issues or possibly mental health. As we all know, Van Gogh had some mental health issues. And so that's kind of an interesting historical side note. Again, not necessarily proven to be true, but kind of fun to think about. All right, hydralazine and isosorbide. This is the brand name Bidil. It's got a very unique role, and it's marketed and studied and was proven to be really only effective in African American patients with New York Heart Association 2 to 4 class, already on an ACE inhibitor or beta blocker. Where it's probably got the best use is not necessarily as an adjunct to those two medications, because I don't know if you're really going to get more benefit than that. But if they have intolerance of that ACE or ARBs, let's say angioedema, this is an option to do it. Not to say you couldn't use it in like a Caucasian or Asian person, but you could. I mean, it's just, again, the benefits there for people with African or Caribbean descent seems to be, I don't know, have better mortality benefits there. It does cause headache in like 50% of people. It's kind of got a flushing vasodilation effect, which causes that type of side effect there. And then the new drug, Entresto, has been out for a couple years now. It's sacubitril plus valsartan. So it's an ARB in combination with this new drug, sacubitril. So sacubitril inhibits neprilysin, and neprilysin is responsible for the degradation of atrial and brain natriuretic peptide. And what those two things do have blood pressure lowering and sodium excretion properties. So that's the way we're affecting it. So it's kind of like so you're combining the ARB with a different mechanism that also works kind of in the kidneys a little bit too, and how the body excretes and degrades these different peptides that have some roles in heart failure. This is the first new drug to come out in heart failure in decades, so it was kind of a big deal. It was studied versus enalapril alone, assuming all other things combined. So let's say they're on a beta blocker and everything else they're supposed to be on. If you replace the ACE inhibitor with sacubitril plus valsartan, what do you find out? They found out there was an absolute reduction in CV disease and all-cause mortality. 3.7% absolute reduction is pretty significant, actually. And again, it was the first drug. When you're comparing it to ACE inhibitors, which already have very strong proven mortality benefits, it's a pretty big deal. There's a lot of patients in the United States with heart failure and worldwide, so that reduction is significant, even though it seems small. So Entresto is brand new. It's really expensive compared to our cheap old ACE inhibitors, so where do we use it in play? The recommendations are currently a little bit vague, but generally speaking, it is an initial therapy option for New York Heart Association class 2 or 3 patients in place of an ACE or ARB. So you could use it right off the bat. In patients who would want to do it would be patients who have current or prior elevated history of natriuretic peptide level. You can test that in the lab and see. Hemodynamic stability with systolic blood pressure over 100. This drug has a lot more hypotension associated with it than the ACE inhibitors. So if somebody is borderline kind of hypotensive already, especially on a beta blocker, you wouldn't want to start this. So they have to have solid SBP before you consider Entresto. Also, angioedema risk is higher than the other two. So that's kind of the interesting thing. You'd be like, well, if you're going to get angioedema on ACE inhibitors, could you use this? Nope, sorry. So it doesn't really have a role there. And if you have no history of angioedema, so if you had angioedema with the ACE or the ARB, you are not going to take this medication. And of course, that should make sense, right? Remember, we talked about ARBs having a strong cross-reactivity, and half of this drug is an ARB. You might wonder, why did they combine it with an ARB? Why can't you get it by itself? I don't really know. All I know is that the Valsartan company that made that drug, invented this drug. So they bundled it together. And I'm not sure if they did that to get more of a potent effect or if they knew something going into their final clinical trials that they had to have this synergy effect to get the benefit with it. Either way, it's got function and use within heart failure patients. It's just, again, it's like, it's a brand name medication. It's going to be hundreds of dollars a month versus pennies for lisinopril. So it's got some work to do, but I think there are good uses for it depending on what criteria you meet. The other flip side of that I didn't really put here, I talked about initial therapy. Obviously, if your patient's not really doing well in heart failure and they've got optimal ACE inhibitor dose without side effects, this would be a good alternative. So there's that side of the coin too. Consider it as maybe like a more potent version, something like that. But insurances will make you jump through a little bit of hoops. We actually have a technician that works with our Minneapolis Heart Association, Minneapolis Heart Institute group, I should say, and her basically sole job is to approve prior authorization. So if they start Entresto on somebody in hospital, she gets all their insurance squared away so that they have that prescription covered by the time they leave, or they know that it's not going to be covered, so they have an answer one way or the other. And she does other things like that, but Entresto is one of the biggest ones that she spends most of her time on, just because insurances don't like to pay for it right away, but she can work her magic and get it covered. Yes. Yep. No. Don't. Yeah, that's really important. Do not combine it with an ACE inhibitor. Right. Yep. It's one or the other. All right, systolic considerations. Blood pressure, again, I've said this a bunch of times. Many patients can't tolerate the ideal dose. Most patients are going to be hypotensive. Higher beta blocker doses are associated with slightly better mortality benefits compared to like higher ACE inhibitor doses. So the point of saying this is if you're picking one or the other, in the patient's hypotensive, decrease the ACE before you decrease the beta blocker. If they're bradycardic, then you have to do the beta blocker, right? So it's all about the hypotension there and which one you decide to. But beta blocker preferred. If you're going to pick a high dose one, better to have the high dose beta blocker and a lower dose ACE inhibitor if you have to pick one or the other. And then the cardiac remodeling I've talked about quite a few times. That's one of the theories behind why there is those huge benefits with both beta blockers and ACE inhibitors. All right, I just want to blast through diastolic really quick. There's not a lot of slides here. We've talked about all the drugs already. The really approach to treatment here is to control hypertension, control tachycardia, reduce preload, and investigate, repair, and treat any potential ischemic sources. ACEs and ARBs, beta blockers. You can use calcium channel blockers in these patients. That's probably the biggest difference. Either dihydropyridine or non-dihydropyridine. Digoxin doesn't really have any effect in these patients. You might increase angina-related admissions too, generally not used in diastolic heart failure. It's another big difference. That's all I have to say about that. All right. Otherwise, again, it's basically hypertension management. That's kind of how you treat diastolic. ACE inhibitors being the preferred option, with beta blockers kind of being the second option. So really similar to what we just talked about, just, again, it's not quite as severe as systolic. Have you guys talked about ventricular assist devices or anything like that in other classes? A little bit. So that's kind of the next step. I don't want to get into that a lot, but a lot of times before somebody gets a transplant, if they have severe heart failure, they'll actually put in a VAD or an LVAD, which is a left ventricular assist device. It's a pump that goes into the ventricle, and so it's kind of a continuous blood flow. So if your heart fails altogether and medications aren't doing it, that's what they go to. So in case you're wondering, like, where do we go or how do we deal with that while somebody's waiting for a heart transplant? Obviously, you don't know when you're going to get a heart. So some people will be on VADs for life. They call it destination until they ultimately die from heart failure, or they'll be on it as a bridge to transplant. So that's the way that we treat heart failure, to go from how do you get from medical management to transplant. All right, does anybody have any heart failure or hypertension related questions or kind of CV stuff that we covered today? All right, thank you.